Hi, good morning everybody. Today I am going to speak about pathology of appendicular malignancies. I thank the organizers to give me an opportunity to speak in this esteemed conference, and here we go. WHO 5th edition, which has come in 2019, much earlier before other editions, divides epithelial lesions into 5 categories: serrated lesions, mucinous neoplasms, adenocarcinomas, goblet cell adenocarcinomas, and neuroendocrine neoplasms. This is just a CAP classification of all appendiceal carcinomas. Last 4 are very rare. Mucinous neoplasms is, I guess, where most of the interest of oncologists and surgical oncologists lie. A brief introduction about benign lesions of the appendix, essentially because in the era of molecular pathology, if a pathologist sees a diverticulum and writes, please correlate with molecular features, please note that even in the diverticulum, which has ruptured and shows mucinous, how do I point it? This one, huh? It shows mucinous deposit on the serosal surface and even KRAS amplification. But the morphology here is important, and one should not be misdiagnosing a diverticulum as a mucinous neoplasm. Other benign lesions can also show molecular abnormalities, but morphology is important. These lesions are not associated with disruption of muscularis mucosa, and they overall maintain the architecture. These are precursor lesions. Coming to the appendicular mucinous neoplasm, in which everybody's interest lies, by definition, they are proliferation of mucinous epithelium with extracellular mucin, and most important thing is they have pushing margins. So one should always ask the pathologist what kind of a margin the tumor has, and destructive kind of a invasion is not allowed in appendiceal mucinous neoplasms. They are associated with KRAS and GNAS mutations. Microsatellite instabilities and BRAF mutations are not seen in that, and on imaging, curvilinear calcification is a specific feature for these type of neoplasms. People started talking about appendiceal neoplasms in as early as 2003. There is a very beautiful article, 2005, and now we have WHO 2019. This is how a low-grade appendiceal mucinous neoplasm looks. If you can see the pushing margin, that's how we should categorize it. See the pushing margin if you can appreciate, and how it rests by destruction of the muscularis mucosa, and it's a very bland epithelium cytologically. This is again a low-grade appendiceal mucinous neoplasm. See how it is invading by pushing margins. High-grade appendiceal mucinous neoplasms by definition are neoplasms in which you get cribriforming or micropapillary. This is true for all GI neoplasms, that cribriforming and micropapillary arrangements in a colonic adenoma also, we call them high grade. Same thing applies here, they are very rare. Destructive or infiltrative type of invasion is not a feature of low-grade appendiceal mucinous neoplasms. This is just a broad category about how we divide different types of neoplasms in the appendix. WHO divides them into 3 grades. G1 is a low-grade appendiceal mucinous neoplasm. G2 and G3 are high-grade appendiceal mucinous neoplasms and mucinous adenocarcinoma. Mucinous adenocarcinoma has an infiltrative kind of an appearance, and signet ring cells, the moment you see signet ring cells, it becomes G3. Most importantly, for surgical oncologists, it is important to remember that the staging of low-grade appendiceal mucinous neoplasms is very different. PTIS is applicable only to the low-grade appendiceal mucinous neoplasms. PTIS also means that when a low-grade appendiceal mucinous neoplasm is confined to the muscularis propria. Otherwise, in GI, when a neoplasm is confined to the lamina propria, we say PTIS. In appendix, in low-grade appendiceal mucinous neoplasm, it is muscularis propria. Even in muscularis propria, one is acellular mucin, one is allowed to call it low grade. T1 and T2 are not applicable for low grade appendiceal mucinous neoplasm. T3 and T4, it's the same, acellular mucin or cells. How you see here a thin fibrous rim, it is not going into the periappendiceal adipose tissue, so still it is PTIS. In the lower slide it is going, so it is T3 and T4 respectively. So this is the difference. Adenocarcinoma has PT1 and PT2. Low-grade appendiceal mucinous neoplasm doesn't have it. All mucinous neoplasms, there exists a T3 and T4A. So this is just an image which shows low-grade, high-grade mucinous adenocarcinoma and signet ring cell. When there is a direct invasion of the adjacent structure, it is called T4A. But when an appendicular neoplasm invades cecum, that is not T4A. That has to be staged according to the depth of invasion in the appendix. When it goes from the serosa and it's going to involve the terminal ileum, that is called T4A. Pseudomyxoma peritonei in context to the appendicular mucinous neoplasms or anywhere is the deposit of mucinous tumor in the peritoneal cavity, where at least 50% of the tumor constitutes extracellular mucin, and usually they are of appendiceal origin. So when we have a low-grade appendiceal neoplasm, usually we have hypocellular mucinous deposits or hypocellular mucinous deposits which are having few epithelial cells without any cytological atypia. The moment we see destructive type of invasion in the peritoneum, it becomes grade 2, and signet ring cells grade 3 in the pseudomyxoma peritonei also. One has to remember that the signet ring cells are true signet ring cells, they are not pseudo signet ring cells, and when the signet ring cells actually invade the peritoneum, that is supposed to be having even a worse prognosis. This is how a pseudomyxoma peritonei looks like. It's a mucinous ascites. Nodal and hematogenous metastasis is unusual. The first one in the right for you guys is a low grade. The one on the top is a grade 2, and the third one has signet ring cells. This is a pointer is not working. But it is not working. Which is the pointer? Pointer is not working. That's it. So pseudomyxoma peritonei is again divided into 3 grades, as I told you. Generally, signet ring is grade 3. Destructive invasion, high grade cytological atypia without signet ring is grade 2. Low grade cytological atypia is grade 3. This is a WHO grade which essentially says the same thing. And coming to the metastasis PM1 cell, this is different from other organs in the sense that cells or mucin beyond the appendix is categorized as P1. But even one has acellular mucin in the peritoneal cavity, it is categorized as PT1A. And PM1B is peritoneal epithelial cells, M1C is non-peritoneal metastasis. So for example, here if you see, that is the topmost is ovary. So sometimes one can get entire ovarian involvement by an appendicular neoplasm, still it is categorized as M1B. Something on the surface of the liver is M1B, but in the parenchyma is M1C. Prognosis and prediction, it essentially is stage dependent, and it depends on the grade of the peritoneal mucinous neoplasm, extent of the disease, and ability to achieve cytoreduction. Addition of HIPAC has improved the survival to 86%. One has to remember in this context that when one has an appendicular neoplasm which is low grade, and in the peritoneum if there is discordance, the overall prognosis of the patient is determined by the grade of the peritoneal metastasis, not by the appendicular metastasis. High grade appendiceal neoplasms are extremely rare. Adenocarcinomas of the appendix, there is nothing different. They behave as like any other adenocarcinomas. They are non-mucinous adenocarcinomas. I would just rush through these slides because there is nothing great. And mucinous adenocarcinomas. Mucinous adenocarcinomas, female predominance, mutations are in KRAS and GNAS. Signet ring cell should have at least 50% signet ring cells, just like any other organs. Goblet cell adenocarcinoma, I am going to spend some time on that because this is an entity unique to the appendix. It is an amphicrine tumor. Amphicrine tumor means in the same tumor you would get a mixture of endocrine and non-endocrine cells. So if you have a tumor in which you have a mixture of mucinous cells, endocrine cells and Paneth cells, it is called a goblet cell adenocarcinoma. One cannot say that please do immunohistochemistry for a definitive diagnosis of goblet cell adenocarcinoma because it's a morphological diagnosis. Synaptochromo are always going to be positive. How we discern it from mixed neuroendocrine, non-neuroendocrine neoplasm is in a mixed neuroendocrine and non-neuroendocrine neoplasm, you would get morphologically and immunohistochemically distinct population of cells, tumor types, and each of that should be at least 30%. Signet ring cell adenocarcinoma differs from goblet cell adenocarcinoma by architecture. Signet ring cell would invade diffusely, and many a times poorly differentiated goblet cell adenocarcinomas can have a signet ring cell component. This is the grading of goblet cell adenocarcinoma: more than 75%, 50 to 75%, and less than 50%. So the topmost is grade 1, grade 2 and grade 3. The pathogenesis of goblet cell adenocarcinoma, what I found interesting is that a subset are associated with gastric signet ring cell adenocarcinoma. You get mutation of CDH1 and RHOA. So somebody finds this mutation, one cannot call it a signet cell adenocarcinoma just because molecular type is showing gastric signet ring cell type. One has to ask the pathologist that how much is the proportion and architecture. And what is important for goblet cell adenocarcinoma is that they are always located in the tip of the appendix. So we sample quite extensively, but importantly when somebody is grossing, it is important to sample the tip of the appendix always, always and always, because goblet cell adenocarcinoma and neuroendocrine tumors both are located in the tip of the appendix. The prognosis depends obviously on the grade and stage, and commonly it metastasizes to the lymph node, peritoneum, abdominal wall and ovary. I thought yesterday we would talk a lot about neuroendocrine tumors, so I have just included one slide. But what I thought I should be speaking about neuroendocrine tumors is there was a discussion about Ki-67 index. The very reason G3 came into existence is because some tumors had Ki-67 more than 20%, but they never responded to the platinum-based chemotherapy. In the past, they were called G3, but neuroendocrine carcinomas. The reason we say well-differentiated neuroendocrine tumor is the tumors which have a Ki-67 between 20 to 55%, they don't respond as well to platinum-based chemotherapy. So if a pathologist is reporting something as a small cell or large cell carcinoma and saying in the report that Ki-67 is only 30%, one has to recheck. Secondly, nuclear imaging versus pathology. Why you need to have pathology is G1 and G2. They are always going to be DOTA positive, but a cutoff like whether the mitosis and Ki-67 is like 10%, 15% or 3%. These are important things for an oncologist to base the treatment and prognosis, so one cannot get away without doing pathology. Staging of appendicular neuroendocrine tumors is important because otherwise other tumors in GI, it is size and depth of invasion. In appendix, it is only size. Like PT1 is 2 centimeter, and you can always get all those things in this thing, so I won't go into detail. So that is where the difference lies. And for neuroendocrine tumors also, they are located in the tip of the appendix. So you have to sample appendix very properly in routine appendectomy specimens also. Thank you so much. These are my references. Thanks.